Aloha, everyone. Welcome, welcome, welcome to the Hawaiian Islands Association for Marriage and Family Therapy's Lunchtime Talk Story. To give us all an opportunity to come together and learn something interesting from some amazing people. Today we are featuring Dr. Adrian Blow. Dr. Adrian Blow grew up in South Africa and obtained his PhD from Purdue University in 1999. He served on the faculty at St. Louis University for 6 years and subsequently joined Michigan State University in 2005, where he is a professor and chair of the Department of Human Development and Family Studies. He's also a member of MSU's Couple and Family Therapy program. Dr. Blow's research focuses broadly on families and trauma, and military families in particular, and on change processes and common factors and interventions pertaining to marital, couple, and family therapy. He's served on the American Association for Marriage and Family Therapy Board in a number of capacities, including as secretary and treasurer. And I just want to say that professionally, I've been aware of Dr. Blow's work for a number of years as I've been doing my own academic and clinical pursuits and followed his work with great admiration. And then more recently, through the HIAMFT and their leadership conferences, I've had the pleasure of getting to know Dr. Blow on a more personal basis, and he's just a really wonderful human being. And Adrian, I'm just so grateful that you're here sharing this time with us. Thank you so much. And if I can just do a plug for you on some important work that you have coming out. There's the book that you're co-authoring right now with Eli Karam on bringing common factors to life. And that's about 1 year away, so look for that book. But more immediately, you have this seminal work, at least that's what I'm calling it, because nothing like this has been written in quite a long time. You were the associate editor on the Handbook of Systemic and Family Therapy, which is available on Amazon and Wiley and other online retailers. You know, if you want an amazing piece of literature to be part of your library, I highly recommend that you see if you can get that collection. So with all that being said, I would like to go ahead and turn it over to you, Dr. Blow.
All right, well, thank you. I don't like those fancy introductions because it sets the expectations really high. So hopefully we should just lower them a little bit, then you can be pleased with what I have to say. So yeah, those works that John talked about are works that I done with some key mentors and colleagues of mine. I work on common factors with Doug Sprinkle, who was my mentor at Purdue, and then I worked with him a number of years. And he passed away about 18 months ago. And then the handbook is work I did with Karen Wampler, who was also a leader in our field. And she passed away in January, kind of got the year off to a terrible start. So, and it's kind of been bad since then, so hopefully it'll get better soon, but it's been a kind of strange year, I'm sure, for you as well. Although you're in Hawaii, so that's, I think every day there's a good day, right? All right, well, I'm speaking to you from Michigan, and as John said, I chair a department here. I've been doing that for about a year. I was the director of the family therapy program here for about 7 years, and I'm still part of that program, but I'm not as involved in the day-to-day operations of that now. So, and I was on the HIAMFT board of directors until the end of last year. So I've been kind of out of the family therapy world for the last 6 months. So this is kind of my first step back into it. So I'm very excited to talk to you all today. In fact, because of COVID-19, I don't talk to many people outside of my university anymore. So this is fantastic. I'm going to share the screen. I do have a PowerPoint. Now, the downside of it is it's way too long. So I'm not going to get through it all in the next 50 minutes, but I'm going to try to hit some high points, and hopefully some of those will be meaningful to you. Feel free to contact me, though. My email is probably the best way these days, and if you have any questions or have any follow-ups that you want to ask, I'll also try to leave some time for questions along the way or at the end. So All right, let me just get this situated here. Okay, so today I'm going to be talking about common factors, and what I've become more interested in recently is how, as family therapists, we deal with a number of complexities in our work. And so a lot of the psychotherapy literature was based upon individual therapy, and then family therapy came along, and there's that whole family therapy literature that you are familiar with. But there's not enough attention that's paid to the complexities of working with couples and families. And I'm going to highlight some of those complexities today. So I'm basically, in my talk today, going to be working to address this question about what are the key differences in skills and in thinking when it comes to working with couples and families versus just individual clients. Okay, I'll start out with a lengthy reading. It's not going to take too long, but it's from an article that came out, actually the date is wrong, came out in 2017. I wrote an article on evidence-based therapists. And in this article, we said that when it comes to working with complex cases and systems, such as those often faced by couple, marital, and family therapists, increased clinical or clinician competencies, talent, and in some, but not all cases, experience are required to achieve success. In this paper, we argue that the role of the therapist in working with these complex systems is even more crucial than in individual-only work. There's personal characteristics and qualities that are more beneficial for couple, marital, and family therapists to possess when we compare to more individually focused practitioners. For example, in our work, we need to be directive and assertive in order to break up dysfunctional couple and family cycles. It's an essential quality in effective family therapy practice. Individual therapists, on the other hand, may do better by remaining more hands-off as they deal with only one client at a time. In spite of the complexities, only a small body of literature has addressed the required skills and competencies of therapists who work in these complex systems. So this was kind of this paper that we wrote in 2017. Really, then this was a paper focused on therapists, and we really, in this paper, really talk about the idea of family therapists, systemic family therapists, where sometimes we're trained in ways to work with these complex systems, but our skills that are required to be successful in these cases are far more. We go on in a second quote here, and we talk about greater skills are needed when delivering interventions to couples and families. This is because in working with these cases, the therapist manages multiple, and in parentheses, often feuding members of a family or couple in the same therapy room at one time, at different stages of development, while at the same time keeping our alliances intact with all these individuals, people who have varying views of the presenting problem and its underlying causes. These therapists are required to work within these larger systems and deliver the best evidence available to treat the presenting the presenting issue. Therapy can easily get off track, or it can get mired down in irrelevant content. But these therapists, that's talking about us, require skill and flexibility and need to be able to rapidly deliver interventions, assess the responses from members of the system, balance the system if needed, all while under a moderate to high degree of emotional pressure. Family therapists are required to manage a great deal of information in the midst of family conflict and to intervene with an appropriate intervention at just the right time, targeting the family members most likely to affect change, all while at the same time controlling his or her own reactivity, like your own values, your own experiences that come up with the family you're working with. So those are two kind of lengthy quotes. But I think the point I'm trying to say today is that the work we do is highly complex, and we have families or couples come in, and again, I don't have to tell you that it's a challenging situation. It's a stressful situation. People are angry at each other. We've got to calm them down. We've got to build a relationship with all these different family members, and then we've got to kind of help them solve the problems that they came in for. That's a big task. Now, I'm going to switch a little bit to talk about common factors, and I'm going to come back to that. So my work in common factors began when I was at Purdue University, and Doug Sprinkler and I, we wrote a chapter on common factors and techniques in couple and family, common factors and non-technique variables in couple and family therapy. And that was published in The Heart and Soul of Change, written by Scott Miller, Barry Duncan, and Mark Hubble. And that book was a pretty popular book, and we got quite a lot of great feedback on that article. But in that article, we were really looking at what is it across all the theories of marriage and family therapy that are common. And we draw pretty heavily from Bruce Wampold's work in that. And Bruce Wampold is a great scholar, and he put forth some ideas about what is responsible for therapeutic change. And he said that if you take a pie and you say, okay, out of this pie, what is responsible for change? He said 86% of change can be attributed to things that have nothing to do with the therapist or therapy. And that's quite a lot. So, so he calls these client extratherapeutic factors and other unexplained factors. So these could be like, you know, you come in and you're depressed and you go to the lottery that week, and maybe you don't need the therapist anymore after that. He also said that treatment effects that were related to therapy had explained about 14% of that pie. So only 14% of change can really be attributed to therapy in his view. And and then he split this down even further, and he said that the therapist, or who the therapist is, explains between 6 and 9% of that variance. So who you are as the therapist is critically important. Besides anything you know, any theories you have, any licenses or credentials, who you are as a person is critically important. And then he went on and he said the alliance, out of that 14%, is associated with about 5 to 7% of the change. And so this is, and I'll talk a little bit later about the alliance and what that is. And so I guess the good and the bad news is that you're the therapist, and you're the key instrument in the Therapeutic Alliance, and you are responsible for, that's approximately 13% of treatment. And then only 1%, in his view, was ascribed to models or to techniques. And so these would be our favorite models: structural therapy, narrative, whatever model we use. In the work that Eli and I wrote, that I read those lengthy quotes out on earlier on, our work was really kind of emphasizing the therapist and what the couple and family therapist brings to the table, and what we can do to improve our skills and deliver better services to our clients. And so I'm going to highlight 3 things today, and hopefully those 3 things will help you in your work. And these are related to common factors that are unique to family therapy. And the first one is conceptualizing difficulties in relational terms. And I'll talk at length about this in a little while, but the thing that I like to think about in terms of conceptualizing difficulties in family terms is that this is a defining factor about who we are as family therapists in our field. I'll come back to that. The second thing we do, and other common factors, in most therapy models, disrupting dysfunctional sequences or relational sequences is a key aspect of our work. So we're trying to change the way, not just, I do some presentations on process. I think that's might be where I first met John. And the whole idea about process in family therapy is you want to change the way people relate to each other in a family or in a relationship. And that's pretty common across all family therapy theories. We also expand our direct treatment system. So in family therapy, another common thing across models is that we don't just work with the individuals that are in the room, but we're also conceptualizing what's going on outside of the room as well. If we're working with a child, we might be intervening in a school system or a school setting or with a court or something like that. But we're thinking at least beyond the four walls of our therapy office. And then the fourth common factor that's pretty unique to family therapy is we expand the Therapeutic Alliance. The traditional conceptualization of the Therapeutic Alliance was the therapist and a client, very Freudian, one client, one therapist, meeting with each other, working through the relationship, working through countertransference and transference issues. Well, in family therapy, we add in these additional layers into the therapy room, alliances with multiple members, and having to manage those alliances. So I'm going to come back to all of these. I'm going to expand on all of these right now. So the first one I want to emphasize is family therapists conceptualize problems systemically. This should, so if you're, I don't know what it's like in Hawaii, but I know there's other people who practice mental health interventions there. And what differentiates you as a family therapist from others who are operating and who are working on the island? So it's the same here where I'm from in Michigan. And this is part of the work that Doug Sprinkler and I did was kind of like looking at kind of this famous battle of the brands, like whose therapy model is better than other therapy models. And that's been going on in psychotherapy for a long time. But I think the defining factor for family therapists is how we think about problems. It's not necessarily the modality of our practice, but it's the conceptualization of the work that we do. Before Karen Wampler passed away, we wrote an article together that came out last year in the Journal of Marital and Family Therapy. And a key argument we make in that paper has to do with the difference between modality and conceptualization. And as family therapists, if you're working, if you're an individual therapist and you're working with parenting, you're going to be thinking very differently than if you're conceptualizing parenting within a systemic context, just as an example. So the conceptualization, when I'm working with, I've worked with, as I said, as John said, I work with trauma, I've worked extensively with eating disorders. The number one thing, I've worked extensively with infidelity in relationships. The number one thing I'm doing when families come into the room is I'm doing an assessment, and in that assessment, I'm building this conceptualization of the problem in relational terms. This is, again, as I say, what I would call a defining feature of family therapists. So having a systemic frame to conceptualize cases. Let's see what else I wanted to say about this. In family therapy, approaches, symptoms, and behaviors are understood within the larger family and its context. An attempt is made to conceptualize it to help the family to conceptualize their problem as something that is connected to their context and which impacts all in their context. The therapist works to help the couple or family come up with a shared view of the problem. And this is achieved largely through changing the frame of the problem from an individual frame to a couple and family frame. So you look at evidence-based models of family therapy, functional family therapy, brief strategic family therapy, emotionally focused couple therapy and family therapy. Those approaches all use extensive reframing in approaching the family, and the goal of extensive reframing is to help family members change the way they view their problems. This is done through, again, working with the whole family system, interrupting sequences, making interventions in external systems. But I think most importantly, in my mind, it starts with helping the family to change how they view the problem, or their attributions related to the problem. Okay. And by the way, if you have any questions, I guess John wave. I can see John and a few of you. So, okay. So now, once we've conceptualized problems in a systemic way, that, in my mind, that's like maybe the most critical part of what we're doing. I'm a pretty big fan of Bill Punsoff's problem-solving therapy. And again, in his work, he talks at length about conceptualizing the problem and what's kind of restraining the problem, or what's kind of getting in the way of problem resolution within the system. I mean, that's a famous systems idea, looking at kind of attempted solutions and defining the problem in its context. And so once we've defined or conceptualized the problem in our minds, and once we've brought family members on board with that conceptualization, then there's multiple strategies that we can try to resolve the problem based on that conceptualization. And so if a kid comes into my office and the presenting problem is ADHD, and if I'm an individually focused, medically oriented person, my first conceptualization is going to be genetic. I'm going to intervene with a drug that's going to maybe work with the biological system to resolve the ADHD. But if I'm, and maybe the drug would help, and so I don't want to discount that. It certainly may help in some cases. But as family therapists, when that kid comes in with ADHD as a presenting problem, we don't start with a biological assumption. We start with a systemic assumption. And so we start to do an assessment of the child, the family context, the school context, the peer system, what's going on in the peer system, and other factors that may be in there. And so we start off with that conceptualization. And then after we conceptualize the problem within that system, we then make a decision about how to intervene. And so maybe we learn that the parents are abusing substances. So then that changes how we intervene with that problem. Or maybe we find out that that child is being bullied at school. And so that changes where we intervene and the point of our intervention. Or maybe we find out that the parents are going through a divorce, and then that might change how we, again, intervene in that situation. So if you get a chance and you'd like to read journal articles, I'd encourage you to read the article that Karen Wampler led last year on, it's called, I can't remember what it's called, but it's a good article. But it's Wampler and the Wampler Blow et al. 2017, and I can probably find it here somewhere if you want that article. But I think it's a really good article where we talk at length about conceptualization of the problem in that article. Okay, so that's one defining factor of family therapists. I think that's one thing that certainly makes us unique. Another thing is, we have to just do some clicking here. Hold on a second. Okay, is to this point I talked about earlier on about evidence-based therapists, or about who you are as a therapist. That makes, so just think about, what would you want if your family was having some problems? What would you want in a therapist? What would you be looking for in a therapist? If you were having some marriage problems or relationship problems, what would you want in a therapist? If your child was acting out and you went to see a family therapist, what would you want in that therapist? Because these questions are really, really important. I think I've been talking to John about this a little bit. You know, how do people these days select therapists? And here, at least here where I live in East Lansing, most people are selecting therapists by going to Psychology Today. And when you go to Psychology Today, you get this smorgasbord of therapists that you can choose from with their picture and their bio. And a lot of people are choosing therapists based on a picture, a bio, and reimbursability. Can they get services reimbursed. And quite frankly, that's not the best way to get a referral. I'm on a therapist list on Facebook in my community, and this regularly drives me crazy, but people will put a referral out there saying we want a referral for couples therapy, and then like all these people will be raising their hands saying I can provide couple therapy. And I know all the couple therapies in my community, couple therapists in my community, and I know that many of the people are not even trained in couples therapy, but they can still see couples. We don't have any, what's the word? We can't stop them from seeing couples. But so when people are looking for couples or looking for couple therapists or family therapists, often they're going to really poor places to get those referrals. But when I'm looking for, if I was looking for a therapist, I'd want somebody who was trained in some of the best practices out there. I'd want somebody who was caring and compassionate, somebody who I felt cared about me and my well-being and cared about my family's well-being. And those are some general things. So in this little study here, in Friedlander et al. 2006, she said that most clients said that a good relationship with their therapy is the most important element of successful therapy. Again, I'd like to have somebody who has a good track record. You might know, but you can graduate with a degree in mental health pretty easily. Well, I don't minimize the work we do, but getting into a program might be the most difficult part of getting your degree in mental health, because it's very difficult to counsel practitioners out of programs. I've been doing this work for over 20 years now, and I can think of one, in all the students I've trained, I can think of one person that was counseled out of the program, and he was counseled out at a pretty late point, and he still went on and got licensed, and he still ended up practicing in the community. And so the only case I can tell you about is of somebody who was counseled out, but the supervisors had very little power to stop him from getting licensed, because he wasn't doing anything like wildly unethical. If someone's doing something wildly unethical, then it's actually much easier to counsel to get them out of the profession. But there's pretty little, this might be a radical statement, but there's pretty little accountability in our field for what people do. Most of the time, people are getting booted out of our profession if they're having sex with clients, or if they're doing something, as I said, grossly unethical. But going back from there, if somebody meets with 40 clients a week and only helps 2 of them, they're going to probably get rich out of that practice. You know, I mean, there's no way, there's no systems of accountability built in. But if I'm looking for a therapist, I'm going to want to try to find somebody with a good success record. And if I'm having a marital problem, I don't want them to have a good success record in treating addictions. I want them to have a good success record in treating relationship problems. And so it's not only a good track record as a therapist, but also a good track record in relation to the problem they're seeking. Now, family therapy as a whole has really focused a lot on models, as opposed to focusing on developing our therapists. And one of the things I want to suggest today is that as we look to the future of our field, I think we would do much better if we focused on looking at who are the best therapists, or who are the therapists that produce the best outcomes, and who are the therapists that produce the best outcomes with certain populations. So not everyone's going to be good at working with couples, not everyone's going to be good at working with children, but how do we know who's, I'm going to pick on John today because he's the only one I really know in this group, but if you were going to go see John for something that he wasn't an expert, John might say, well, I'll try, I'll give it my best shot, I'll read a book on it, but what if one of you had a better expertise in that? So we've kind of set up the system where we compete against each other, and we don't really have a way to as I said, to track who's doing the best work in certain areas, and we don't have good feedback loops in that process. Okay, so in family therapy, when I'm looking for some therapist variables, I'm looking for therapists that are responsive to the needs of clients, that they're good at, like, one of the skills I think we need in family therapies, therapists who can make good decisions. You know, when you're working with a family, you get faced with numerous choice points in therapy. You can decide along the way what question to ask, or what emotion to punctuate, or who to ask a question to, or how to ask a question. These are all decision-making skills of therapists. And sometimes it's knowing when to be quiet, when to do a reframe, when to ask what those tears mean, ask somebody to talk to somebody else in the room. Those are all decision-making points. And I think decision-making, by the way, is based on our conceptualization. I also want to add that our decision-making can be fuzzied or made fuzzy by not having our issues, our own personal issues, under control. So I supervise a lot of students who work with couples or families, and when families are pressing their buttons, I'm seeing students make some pretty bad decisions about how to proceed in therapy, because they're activated and their emotions are activated, and that influences how they make decisions. I think therapists have to be flexible in their work. They have to be creative often. I think responsivity is an important one. I think the best therapists don't tend to follow a set formula or procedure for change. Now, they may have principles that guide their work, and certainly models that guide their work, but I think the best therapists are more kind of like musicians who are kind of jamming in a I'm not a musician, but who are, you know, in a jazz band, and they kind of are playing, but they're also feeding off each other, and they're getting feedback maybe from the audience about how things are going. And so they have these guidelines about what they want to sound like, but it's also, it's not necessarily one paint by numbers, do this, do this, do this. It's much more creative than that. So it's not necessarily a step-by-step approach, but it's something that works through the therapist, the decision-making ability of the therapist, personal style of the therapist's prior experience, and training and supervision. I just want to emphasize that prior experience, there's actually not a lot of research saying that prior experience makes a massive difference in therapy. Even though intuitively it would, I think it depends. I think in some cases prior experience makes a difference. In some cases, prior experience, how we work with families. So for example, if you work with a couple and there's violence and there's a explosion in the therapy room, when you work with couples again, you might say, well, all couples are violent. I'm going to then treat them, you know, in this, I guess you might overreact is what I'm saying. Whereas instead of doing that, there might be just a few screening questions you could add that wouldn't be necessarily be an overreaction. So, but I'm going to move on for the sake. Oh, I just wanted to mention, I also added just a point there about deliberate practice. I think John said that Scott Miller talked to you a little while ago, and you might hear this word deliberate practice coming up. It's quite a popular word these days in psychotherapy training. All deliberate practice he's talking about is that we need to hone our skills as therapists. So if you were trying out just to be a violin expert, to be an expert violin player, you probably need to be practicing violin every day for several hours a day to kind of get to a level of expertise. And you need to be getting some feedback on your violin playing and how that's going. Deliberate practice, people say you should videotape your work. You should watch your work, review your work. You should practice it, then you should try again, videotape it again, and then you should get feedback from an external supervisor or an external source. My kids all play soccer, and they play way too much soccer. They play on travel soccer teams and things like that. And so they practice in just about every day. But practicing is not enough to make you a good soccer player. You have to get some critical feedback on your play as well. So it's not just about kicking the ball. It's how you kick the ball, who you kick the ball to, and numbers of other things that occur. But my point is that you have to practice, but you also have to practice with the right kind of feedback. That's a lot of what deliberate practice is. And in our training programs, I don't think we've done enough to help our therapists master core skills that help them to be effective family therapists in their work. Okay, the third area I want to move on to is, let me see if I can move there quickly, is the Therapeutic Alliance. And so, again, if I had all day to lecture, I'd lecture about other things here, but the three things that I think are critically important are conceptualization of cases, who you are as a therapist and how you hone your skills, how you become really adept at what you do, how you make good decisions. The third area is the Therapeutic Alliance. Okay. I realize there may be questions, but let me get through this and I'll leave. I'll try to end in 10 minutes and then I'll take some questions. So the Therapeutic Alliance is really important in all psychotherapy, but it's really important in systemic family therapy, because we can't just have an alliance with one person. And I think this is where our work becomes especially difficult. As I said, I've worked a lot with infidelity. A pretty common presenting problem if you work with couples, you're going to have probably about 20% of your cases where there's infidelity or those kind of issues come up. Now, in this situation, those couples who come in are highly emotionally activated. There's often a person we could call the offending party and a person who could call the hurt party. These require very different alliances. Now, I'm going to say you always want to have a good alliance with the hurt party in those cases, because that's somebody you need to give extra support and attention to, and they're going to be especially fragile and vulnerable. But the person who is the offending party often gets neglected by the therapist. But you want both those parties to be on board and engaged in therapy if your treatment is going to be effective. So when it comes to working with individuals, it's quite easy just to kind of pour all of our attention into that one person and be very validating and attuned and responsive and listening. But especially when you're working with families or couples where there's this conflicting agenda or intense, maybe a conflictual relationship going on, that's triggering for therapists. And how do we feel kind of connected to both or more than two people in the therapy room? So it's really especially important when it comes to working with couples and families. It's especially important early on in treatment. There's quite a lot of research on this variable that the early alliance is the most predictive of successful outcomes. If you botch your alliance early on, don't do a good job, there's actually not always enough opportunities to fix that. So no pressure there. In the work I do with couples where there's post-traumatic stress disorder, I work a lot with National Guard families here in Michigan where there's things like that. It's very difficult to get some of those clients to show up for therapy. And so really building a strong alliance early on is critical, because in those cases, I know that treatment normally lasts more than one session, right? It's normally going to last 15 to 20 sessions, maybe 6 months for them to get optimal help. So you don't want to rush it, but you also want to make sure that you can engage them pretty well early on. The alliance is not enough talked about in terms of what the alliance is, but let me just emphasize if you don't know this already. Number one, in family therapy, especially, it's important. It's agreement between the therapist and the clients about the goals of therapy. This is especially important in mixed agenda family members where they each have a different agenda. They're all trying to go in a different direction. But the more you can get them to agree on the goals of treatment, the better. And sometimes you really got to shift your goals, maybe to broad meta goals. Maybe your goal then, if they don't agree, would be to come on. Our goal for the next 2 sessions is to try to come up with a shared view of why you're here. You know, that might be the goal for treatment, but having a goal that everyone can feel good about is really, really important. If a family drags their adolescent in and says, we're here to fix our adolescent, and the adolescent says, I'm not going to talk, it's going to be very difficult to have productive family therapy sessions. So our goal, number one, we want clients, the therapist and the clients, as much as possible to agree on why they're in treatment. Sometimes this is easier, by the way, in mandated therapy cases, because you can say the judge said the goal of treatment is this. But still, for clients to do work in therapy, they need to feel invested in goals. Number two, they also need to be invested in the therapy tasks that are going to be used to accomplish those goals. Some of you, I'm sure, are familiar with emotionally focused therapy and maybe use that in your work with couples primarily. I already love that model. It's a great model. But there is one contraindication, or there's a couple of contraindications for that model. That model doesn't work well for on this dimension if clients are not comfortable with emotions. So that might seem obvious, but that's kind of a task dimension of the alliance. So maybe you're working with, I'm just going to stereotype here, an engineer who just thinks things all the time, and you're saying, okay, we're going to focus on your sadness, and that might be way, way uncomfortable for that engineer. He or she's going to quit. And so that doesn't help us at all at that point. So it doesn't mean that we don't get to emotions eventually, but maybe we start out being more cognitive or more rational in the way we approach that work, maybe more behavioral. But this is really important, that clients need to feel really comfortable in the tasks we use in therapy. Also, I just want to say that cultural variables are really, really important here in this aspect of the alliance, because different cultures are much more comfortable with different tasks that you use in therapy. And so you also have to be really thinking through, like, culturally, how does this intervention or this approach work or fit with this particular cultural group? So one way to address that is really to get a lot of feedback on that. And then the third aspect of the alliance is the effective bonds that are necessary to sustain the hard work of therapy. I'm not going to have enough time to go into this today, but establishing therapeutic safety is a really critical factor in family therapy work. When people feel safe in therapy, their walls come down, their defenses come down, they're able to be more vulnerable. I had a paper come out that was led by my student Tim Welsh in the Journal of Marital and Family Therapy. It came out a few months ago. And in this study, we looked at emotionally focused therapy and what therapists do to establish safety early on in the therapy. Because in emotionally focused therapy, you're really asking clients to do a lot. You're asking them to really kind of open up their heart and soul to each other, to share their more vulnerable feelings with each other, to take risks of vulnerability with each other. And if they don't feel safe, or if it's not safe, sometimes it's not just a feeling, it's like a reality. You know, you've seen those cases where someone will take a risk and share some tears and their partner will be like, you know, what? You know, they'll just not be there for them. And so those kind of recreate like painful memories or painful experiences, and we try not to do that. So it's really, really important that as part of the effective bonds of the alliance, that therapists do a really good job of establishing safety in therapy. Okay, the last thing I'm going to talk about, and I have a lot more I could share, but I'm going to skip ahead because I did say I was going to leave some time for questions, is I just want to talk briefly about feedback, because feedback is really, really important. And this is a growing, so I'm skipping, like I told John I had way too many slides, and he validated that really well. But I just want to talk about monitoring the alliance, because this is really, really, really important. I think this is maybe the most critical thing that you can do in the Alliance, and this is through obtaining feedback from your clients. You can obtain feedback both verbally or through written feedback measures. This is needed because therapists routinely overestimate their effectiveness. We always think we're doing better than we are. I've been in therapy maybe with 3 or 4 different therapists at various times along the way. And I'll say that if I'm ever your client, I'm a terrible person for giving you honest feedback. I want my therapist to feel good, and I don't like giving like negative feedback. I'll probably just quit therapy before I give you like feedback that'll hurt you. Now, other clients don't have a problem letting you know exactly what they think and that you screwed up, and they're ready to let that hang out. But most of the times, therapists are overestimating their effectiveness, and only about 3% are routinely tracking their outcomes. The effectiveness of the average therapist plateaus very early as we get into this automatic, what Bob Berlino talks about it as automaticity. And this has serious implications for the Alliance. So you might be familiar with some of the feedback literature. If you Google the outcome rating scale and the session rating scale, those are free downloads. I'm not going to go into those things today. But getting feedback or monitoring the Alliance helps you to understand more about how things are going in therapy, and it helps you to respond more to how things are going in therapy. And I found this very useful when I'm working with multiple people in the room at the same time, that you get different feedback from them. So it's not just getting the feedback from them, but it's also then processing the differences in their experience. It's a very key variable in deepening the process in therapy. So if you're working with a couple, it's a heterosexual couple, and the male client says, this isn't working for me, and the female client says, this is the best therapy I've ever had, like that's an important split variable in the therapy. And so what do you do with that feedback? Well, the feedback experts suggest that you have a conversation about it. Again, to try to bring people more and more on the same page together. Let's see. I'll end with this study here that I think is maybe one of the most important family therapy studies to come out. This is published by Anker Duncan and Sparks in the Journal of Consultant and Clinical Psychology in 2009. In this study, there were 461 Norwegian couples in marital therapy, so a really good sample size. And there were 2 treatment conditions. The first condition was just routine marital therapy with no feedback. So the therapist could work with couples, they could practice whatever kind of therapy they wanted. There was no prescribed model or formula. They were just told to do their usual work. The second and comparison condition was routine marital therapy plus feedback. And so the findings of the study were, I think, remarkable. The treatment as usual condition with no feedback, those couples, only 17% met the what would be called an improvement criterion, or met a satisfactory outcome as a result of the treatment. But treatment as usual plus feedback, 51% of those couples met or exceeded the target. So this is a pretty remarkable finding, I think, and statistically the effect size difference here is huge. 50% at the 1-year follow-up, even more remarkable, had less separation and divorce at 1-year feedback, which that's a pretty difficult outcome to measure, by the way, in couples therapy studies, just because sometimes a divorce or separation can be a good outcome. Anyway, all I'm saying is the findings from this study, all it suggests is that practice your regular work, but if you add in feedback that is formalized at some level, outcomes are going to improve tremendously. Okay, I'm going to open up for questions. It looks like I have like six minutes. So thank you for your time. And I'm going to move this on to the last slide so that if you have any questions, you can you can let me have them. Sorry, if you want to email me, you can email me. Okay, here's my information there.
So Adrian, have you noticed any differences between telehealth therapy and in-person therapy?
Well, I have done no telehealth therapy. When I stepped into this role of department chair that I've done, so for the last 6 months, I quit seeing clients just so I could focus on that new job. But my wife, who is also a therapist and who lives in the same house as me, I see her do therapy every day. I don't see her, but I hear about it because she's in an upstairs room and she sees clients there all day long. And there certainly is a difference. So it definitely takes some skills, especially to manage. I think what we're good at is kind of the here and now aspects of working with process in the moment. And I think that for me is kind of the critical difference, even in the students that I work with, is how do you bring kind of a interactional process into the here and now? That's what family therapists are really good at. How do you do a reenactment or those types of things? So that's a really good question, but I haven't, but I bet you all have seen, I bet you all have way more answers than I have. So.
Yeah. Any other questions that folks might have? We've got about 4 minutes left here. I see a lot of people are saying thank you, Adrian. A couple people wondering if they could get a copy of your PowerPoint.
Yep, sure.
One person asked if there'd be a part 2. You can go through the rest of your slides. So maybe we'll talk about that at some point.
Well, the problem is it's not really a part 2. The problem is I can just talk all day about it. So it's really kind of yeah. I'm happy to talk again at some point, and I can just focus on one aspect of our work. But I was trying to give you maybe more just of an overview today. I think there's numerous exercises we could do to kind of deepen our understanding of some of these concepts. But I'll share the PowerPoint as soon as we're done. I'll share it with John, and then he can distribute it however he wants.
Great. Adrian, I just want to ask one question about the multicultural applicability, if you will, sort of universality. One participant asked about that. Any thoughts about multicultural applicability? Yeah,
so I'll just give an example. So last year I was over in South Africa, where I came from, and we delivered a intervention, a Hold Me Tight intervention, which is based on Sue Johnson's work, and we delivered it in a group format. But in South Africa, there's really wide cultural variation in cultures, and it comes down to language, and it comes down to religion, and there's just all these different cultural variables, and different cultural groups accepted this intervention differently. So one of the modules in the intervention was related to sexuality, and in our group, some of the cultural groups were very excited to get this new information on sexuality and improving their sex lives, and went home and talked about it at length. But some of the other cultural groups were very uncomfortable with the topic, and they were like, that was way too much, and we didn't want to know that, and it was very difficult for us to talk about it. And that's just like a real life example that came from an intervention with just numerous cultural groups together in a setting. But that kind of that's that alliance thing, and ideally, having different cultures in a multicultural group is a challenge. But when you're working with couples in therapy, some of them are just going to be much more comfortable with certain ways of thinking about therapy or thinking about change, and we really have to be adapting our work to them and to their contexts. And I'm not saying we shouldn't challenge our clients or push our clients, because sometimes we do need to push them out of their comfort zones, because if someone's never going to look at their emotions, and that might not be healthy for them at all, especially if it's connected to their presenting problems or to how you conceptualize them. But at the same time, we have to be highly sensitive to what's going to work with them as well.
Makes sense. So really focusing again on that relationship, that thing that we have some sort of influence on, that relationship.
Exactly. And we may have a great theory and we may have a great conceptualization, but if we say, well, this person's stuck in some past trauma and my goal is to help them to get to that trauma and let it go through some great technique I have, well, if they don't want to go there, if they're really uncomfortable going there, or if they feel really unsafe going there, then our conceptualization is just ready for us. It doesn't really mean anything to them. And so our goal is to help them with their problems. And so meeting them again where they're at culturally with their belief systems and what's going to work really well with them and what's really, from their cultural perspective, meaningful to them, I think is really critically important.
Wow. Dr. Blow, I can't thank you enough for sharing this hour with us. On behalf of all of us here in Hawaii, mahalo nui loa. And to everyone that attended, thank you so much for being here today. If you have additional questions after this, feel free to reach out to myself, to Dr. Blow, or to Janet Covington. And we'll just hopefully see you next time. Have a wonderful rest of your day, everyone. Aloha.
Aloha, thank you.
Bye-bye.